lunch. Obviously, the first session back, second day after lunch is the headline out. So thank you for joining us. The whole session is going to focus on career pathways. So again, I talked a bit more about today being about early career pathways. We've got 3 individual speakers coming to present their career pathways to us. Huge variation in backgrounds and journeys and stuff. So it should be a really interesting topic. I'm not going to introduce the speakers straight off. They can introduce themselves as they come through. We can get the context of their intros. First up, Mark.
Yeah, thank you very much. And yeah, technology is working with us today. So apparently my title is Clinicians Who Code, From Ward to Workflow, a Clinician's Journey into Coding in Healthcare Informatics. Hello, everyone. Good afternoon. My name's Mark Bailey. I'm going to jump into my slides in a sec, but I might talk way too long or way too little, but I like to get some questions in there from people as well. I think most people that I speak to, and even today speaking to people, most people I speak to about digital health, how do you get where you are? I think most people kind of say in one way or another, they fall into it. Whether it's a good thing or a bad thing, they just happen to be the person that can fix the printer. So then they're connecting up the switch and the router and the whole network the next day. There's a few smiles of people actually acknowledging that. You know a little bit about technology, you get thrown in the deep end trying to fix it. But I sort of fell into it as well. And I'll kind of take you through the journey of how I got there. It's very convoluted, very complicated. I would not recommend anyone else taking this route to get there, because I started outside of medicine and digital completely. I started in chemistry, not a pharmacist, actually in chemistry, mixing chemicals in a lab and working in pharmaceutical industry. So I did a BSc in chemistry, then a PhD, worked for the pharmaceutical industry, a company called Teva, which some of you may know if you do pharmacy. They do a lot of generics. And I realized working with Teva that actually I enjoy, I was testing the drugs, not myself, in a lab. I was testing the drugs and realized I'd rather, mixing these drugs, testing them, I'd rather be prescribing them. So I thought, okay, let's jump into medicine. So that's where the story starts in terms of digital health. I'm now actually doing medicine. But interestingly, in my first year in chemistry, I did do with computer sciences. I have come full circle with the digital side of things. So I graduated in 2013 doing a graduate course because I've already done a degree. And I started in pediatrics. I thought, going through med school, I was like, oh, pediatrics would be fun. Lots of kids to play with, play with their toys. Oh, it's stressful, that. Parents being stressed out with their kids being sick. In hindsight, it makes perfect sense that the parents would be the difficult part. I found the kids were fine. They could be as sick as they're going to be. But actually, the parents asking every 10 seconds what's going on, and being really anxious. I used to go home with locked jaw from that job. I did that for a year, and I realized it's not for me. So I went into general medicine. And in some ways, pediatrics is respiratory medicine. There's lots of coughs and colds. I went into the adult version of that, respiratory medicine. And that's where I sit right now. I am a locum respiratory and general medicine consultant at Great Western Hospital in Swindon. Now, digital. When I started respiratory medicine in Gloucester in 2017, I was asked to help with digitizing. Well, they didn't use the words digital. I was asked to help with improving the sleep service, so sleep apnea syndrome service there. And there was a backlog of 300 patients waiting over a year to actually get diagnosis and actually treatment with the CPAP masks. And I was like going through the reports, dictating them and saying the same thing. You have sleep syndrome. It's mild, moderate, severe. You're overweight. You need to lose weight. You smoke. You need to stop. You need a CPAP machine. Over and over and over and over. Now, some people in the room, you might think, well, you could automate that. That's what I thought as well. So I started actually thinking of ways to automate that. So I did what anyone would do. I put some macros on it and automated making those letters. So I just have a little drop down, mild, moderate, severe, and change all the other things. You're smoking, you're overweight, so on, contact the DVLA, all those sort of things. Press print, and then the secretaries will put it in an envelope and send it off. Well, that's bloody awesome, that, but it's actually, there's 300 patients and I have to do that individually for each one. it's quite lengthy. So then I went, oh, Excel, let's do an Excel. I did an Excel spreadsheet, you press a button, I'll fill out all the patients, press a button and it'll print out this letter that the secretary to send off. Okay, still doesn't feel fancy enough. Let's try something else. I found we had Microsoft Access on our computers installed there. A few nods in the room. That's basically just Microsoft's database that you can play with. And I was trying to find other things, but actually we weren't allowed to do any open source things or build externally things. We had Microsoft Access, so I was like, okay, I'll use that. I'll start building with that. And that started the Spiritum, Spiritum being Latin for breed. We thought it was a great name for, a system in a respiratory department. We started building that. Well, I started building it, and then we started using it. And it connecting to different systems. I didn't know about clinical safety at the time. I didn't know about, clinical safety officers and, actually going through the boards. I was just building this in my own time, hacking it away. And of course, in 2020, when COVID hit, I had a lot of free time because all our clinics were cancelled. So it's like my bosses asked me, oh, can you just build some more things? And I built Spiritum to actually help manage the whole sleep service. And it still manages the sleep service, bronchiectasis and tuberculosis in Gloucestershire, that one system. If it were great right now, I'm not sure who's going to fix it. I'm the only person who knows the code, so they're going to have to give me a call, and we'll see what we can do. But yeah, there's interesting issues there, but that's for another day. That's Spiritum. We've done some work on also automating with robotic process automation, RPA, with quick Spiritum, and then Spiritum Duo was lung cancer pathway management and so on. Now, I've worked in industry on and off over the last, 2 or 3 years. The Sleep Station, they do insomnia treatment with their nice little app. We've got Canvas in the States and San Francisco, not in the Bay Area, outside of the Bay Area, so not Silicon Valley. And they asked me and a few colleagues to do some research around LLM usage and EPRs. That was interesting. It really got me into LLMs and understanding the quirks behind it, the pros and the cons and the danger side, which we kind of heard about today as well. Lindus, where I worked over the winter this last year, I was working on their clinical studies system and Onion.ai, where I'm working at the moment as a chief technical officer, and you'll hear from my boss a bit later today with whom. So other things I've done as well. Used to be very involved with the FCI, the Faculty of Clinical Informatics. It's very interesting to see that we've got 3 generations of chair of council in the room today, with John Williams and Jonathan Kay at the back there as well, and myself as interim chair. And a lot of you probably know the story around the FCI, internal politics and funding issues, something we could discuss over a beer some other time. Though I have discussed it in a webinar recently with my colleague Marcus Bohr, who's doing some YouTube videos. So wait for that to come out and you can see what we have to say about that. But unfortunately, yes, the FCI sort of dissolved / reabsorbed into the VCS, which is a nice home for it at the moment. We see where that goes. I'm also a board member for the NHS Python community. And in terms of other studies I've done around digital health, there's the Masters in Digital Leadership I've done from the NHS Digital Leadership Academy and Imperial College London. So that seems like a lot I've done to get where I am. Very convoluted, very complicated. I would not recommend that for anyone. But people ask, especially who are new to this arena, how do I jump on, the bandwagon? How do I get into this specialty? How do I actually start practicing or, educating myself on this? And there's no one way to do it. Is that an issue? I don't know. But I think it can be difficult, especially with people that haven't got the motivation to actually, get involved with things. That's one way to do it. Just show your abilities in digital health, get involved with projects where you can, and just build up your network and your skills and so on. I might have overdone it, but I like being busy as well. So hence all the different things that I've been doing. Now, another thing that I've been doing as well is something called Let's Do Digital. I am the community lead for this. It's been going on for the last, this is the 4th year now. It became a legal entity last year, where we provide webinars around digital health, teaching materials of teaching people how to code. I think of myself as a clinician who codes, and I've been teaching other clinicians and just techie people how to actually write programs and understand how it all works, the data analysis and stuff like that around there. We got a conference coming up, 23rd, 24th of October. If we can do that small plug in Painswick, please do come and join us. And also building a few other apps for different people. So really my big passion is building better digital health. Now, what that means, everyone's got their own opinion on that, and we have questions and so on about that. But my real passion is, I haven't worked out the best way to phrase this, but excellent user-centered design. If that's a thing that could exist, I really want it. Right, so what am I doing at the moment? I kind of alluded to most of them. Locum consultant general medicine, on a respiratory board, but we haven't got many respiratory patients. So I think of myself a general medicine consultant at the moment. Chief Technical Officer for Onion AI. Clinical Informatician at the Bennett Institute in Oxford. I just started that a few months ago. Working with Ben Goldacre is lots of fun, especially the weekly meetings when he gets to tell us what is and isn't happening within the NHS and the funding that is and isn't there. Hopefully we'll be doing some mental health educational stuff there. We'll see. All about funding really at the end of the day. As I said, the community lead for Let's Do Digital as well. Final plug. If you want to hear more about what I'm doing or my colleagues are doing, we have a conference as well later this month. Very much. Do you want to take questions later?
Yeah, we'll do one set of questions at the end.
Okay, fantastic. Thank you very much.
Good afternoon, everyone. I'm really honored to be able to be with you today and to talk about my career pathway in health informatics. My name is Riham. I am a nurse, originally from Syria. I came to the UK in 2020, September 2020, so 5 years ago, to do a master's in healthcare operational management at the University of Warwick. Where my journey started as a Chevening scholarship. Chevening is a scholarship from the UK government to young leaders in their sectors to do master's degree in the UK. So thank you. So I did the master's related to healthcare operational management at University of Warwick, where I studied health informatics, digital health, telemedicine, electronic health record. I didn't want to be a qualified nurse in the UK, and I fell in love in digital and informatics. And after my master's, I tried to secure a career with the NHS or in the digital health sector in general, and it was really difficult because of COVID and so on. So I thought like maybe I need a different path, maybe academia, to have like a robust knowledge and background related to the informatics and digital health. And then I applied for a PhD, a scholarship to do a PhD in the University of Warwick and to study the implementation of electronic patient record in the ICS of Coventry and Warwickshire. Then I started my PhD. Now I'm about to finish data collection, researching the implementation of EPR for population health management in the ICS of Coventry and Warwickshire with a focus on health inequalities. However, I didn't actually at the beginning speak the same language of the clinicians or the same language they speak in the NHS. My terminologies were like different, and from different educational system, English is not my first language and so on. So it was at the beginning really difficult to know what to do, what kind of skills do I need to build, and what are the opportunities as well. Then the Future Digital Leader Bursary Program was like an eye-opening and amazing opportunity for me to join the program and to join a summer school over 2-3 days in Birmingham University, where I met lots of like clinicians and senior clinicians and people are doing different careers and in the health informatics and within the NHS. That program helped me a lot to navigate what do I need to do next, what kind of skills do I need to build. And it was an opportunity to talk to clinicians, to ask them for advices, for like feedback on my CV, what kind of things can I do to build my knowledge and to start like applying for jobs in the NHS and to get an opportunity to learn more and to build my skills. And after that program, actually, and as I said, it was an eye-opening. I was able to get a job in George Eliot Hospital as a clinical informatics research fellow. So in my current job, I help in applying AI tools and implementing AI tools like speech recognition, like ambient AI, and the different AI tools for example, dictating fractures and so on in the trust. So from like a junior nurse to be in a different country, to be in a different healthcare system, and now I'm part of that system. Now I'm able to do like a positive impact and bridging the between academia and practice. So I am able now in my current job to apply what I learned from the literature in practice and the as well. So being as a clinical informatician is really helping me to for example, interview participants, to recruit participants for my PhD, and also to apply the knowledge from my PhD in real practice through like a formative feedback, for example, for the ICS, for the ICB members, and to the trusts as well. My career, I think, is different. It's a long one, like through the PhD and so on, but I'm enjoying it so much. It's really like rewarding. Thinking about the last 5 years, being new in the country, and now I'm here with you, able to talk about my career pathway. It's really a pleasure. And I've learned like few things during the journey. So what my journey had taught me actually is like to never give up. It is my slogan. So opportunities are unlimited and to never give up. At the beginning, my journey started with, I would say, like obstacles of COVID and being in different country. But then of keep like trying and taking baby steps to build my skills and connections and network. So I am in different place in terms of career, and also to think like there's no one single pathway to health informatics or to digital health. The pathway might be different, and at the beginning I used to say yes to all opportunities, even without knowing, the full picture about it, or even if it's out of my comfort zone, I used to say yes. But then over time I started to be also specific, because my career pathway started to be like more clear, and then I can now like know, okay, which job to apply to or which opportunity to seek and so on. As well, like mentorship and network played like a crucial role in my career pathway, especially the future digital program for future digital health leaders. And I would like actually like to ask all the senior professionals in the room today to please like allocate time for the feedback, for the advices from your staff to junior professionals, because it's really crucial for someone like me to navigate the landscape of digital health and clinical informatics, and also building the skills of like technical skills and also leadership skills. I found it really, really important to be able to talk to clinicians in practice, and at the same time also use the technical terms and the technical skills. And thank you so much for listening to me. Thank you.
Like that was a surprise for me now to be on them slides as well.
I'm on the and I think the jiggy balls.
Screen them for them too, I think. And in on your screen in front of you, so. Twice. Yes.
While we're getting that up on the screen, my name's Ong Myatt. I am a academic interventional cardiologist, plus also a senior medical director at a contract research organization called MedPace. My thanks to the organizers for inviting me to speak today. Much like Mark and Leanne, my career has been certainly a portfolio career, I would say. It's taken its sort of turns here and there. It's been fairly meandering as opposed to a sort of straight trajectory, and we'll go through it. So I started med school in 1994. That's me, the top left. Probably not my finest hour, but that was the final year of med school. Guys and St. Thomas's. We were about to celebrate the millennium coming in. It was about 11 p.m. in a Stockholm nightclub. We somehow managed to get in, but I basically drunk myself to oblivion, and we were tucked out of the nightclub before the midnight came in. So medical school was a bit of a blur, but I managed to get through. My friends have never allowed me to forget that night, but it was quite the moment. So graduated in 2000. The next 20 years was spent in the NHS. Cardiology, especially interventional cardiology, is extremely competitive. You can't just be a clinician, you have to be a researcher, an academic, a clinical trialist, have a postgraduate degree, etc., etc. So it's definitely a long path, but certainly a fulfilling one for me. During that time, I developed a whole series of textbooks for Oxford University Press called the Challenging Concepts series of textbooks. I've written myself 3 textbooks, so very much into writing, peer reviewing, publishing, academia, research, but also I loved putting wires down people's heart arteries and inflating balloons and putting bits of metal in them. So this picture was probably the highlight of my clinical practice. This was deep into COVID, all the gear and hopefully a bit of a clue as well. That was a primary angioplasty. So this is an acute heart attack coming into the hospital. It's 3 a.m. The whole team had sort of done their day shifts. We were all broken as medics, and as a multidisciplinary team, we'd done our day shift. We thought we'd hopefully have a quiet night, but we didn't. But it's really the sort of pinnacle of teamwork, knowing your job, having your skill set, having that commitment to do what you're trained to do. And in that situation with with a patient with an acute heart attack, there's a good chance of a cardiac arrest, intubation, lots of aerosolization of COVID. So you're not only saving someone's life, you're also putting your life at risk as well. So that the process of getting that patient through the procedure, effectively saving their lives, having the team around you doing, being with you in that journey, I don't think I'll ever have a greater sense of satisfaction ever. But having said all that, after 20 years, I found that I preferred academia, clinical trials, medical education, digital health, all that. I preferred that more than thinking of having to wake up at 2 in the morning for the next 20 years of my life doing primary angioplasty. So I thought long and hard about it. During that 21 years in the NHS, I built up a big network of academics, people in industry, people in pharma. So I had people to call, I had people to get advice from, and I thought, I basically had enough of clinical practice. I was getting up in the mornings and wasn't wanting to go to work. And I didn't really enjoy the commute. I didn't enjoy clinic. Sadly, I didn't enjoy ward rounds. I didn't even enjoy the cath lab. So it was a time to sort of break free, make a clear break. And I just took the step. So these photos were literally my last day in the NHS. Lovely team. It's an amazing, at its core, the NHS is amazing. I'm deeply passionate about it, but it wasn't for me. So I got job offers from Medtronic, Pfizer, AstraZeneca, Johnson & Johnson, but these companies are behemoths of companies. They have 100 to 150,000 employees. They take forever to make a decision. They were umming and ahhing about contracts and remuneration and salary and et cetera, and I just didn't want to wait around. So I applied directly to MedPace. I didn't even know what they did, but I looked at their job description on LinkedIn and I looked at all the bullet points and thought, I can do this job. It's pretty straightforward. It's about clinical research. It's about finding new treatments. So I thought I'd apply. Didn't get a response for 8 weeks, then got a call on my mobile. Senior vice president rang and said, he didn't even interview me, said, do you want a job? So I had to think about it a little bit. But I thought, why not? Let's do it. So that was July 2021. This is the campus in Cincinnati. It's an American company, but we're global. It's all started by one man who was also a doctor, entrepreneur, built it from the ground up to now 6,500 employees, market cap of about $15 billion, share price of $500 on NASDAQ. So the man has done really, really well. And he's still managing the company and every sort of path within that company. It's a great job. We get to perform or oversee clinical trials that really bring the most up-to-date, most contemporaneous drugs to market. So, I'm currently running 15 global clinical trials. So it's a very, very busy job, and the Americans start about midday. So I start with the Europeans at 9 o'clock in the morning. So I go on to about 7 or 8 in the evening with the Americans. But it's eye-opening in that it's far more meritocratic in industry. You do your hours, you do your job, you become visible. I still get to do my digital health bits and all the academia as well. And you get recognized, you get remunerated properly, you get your holidays, you get every weekend off, you get 2 weeks off at Christmas, etc., etc. So I look forward to my work when I wake up in the morning, and I didn't do that, towards the end of my career in the NHS. So all tickety-boo. But then this happened. So we were asked by a sponsor, small biotech. They had a small interfering RNA compound. They wanted to investigate it in calcific aortic stenosis, which is a degenerative disease. They came to us and said, look, we've got a protocol. We want you to set up a patient and public information group workshop, get people's opinions of whether they would like to participate in our trial. So I said, yeah, let's do it. So got 16 predominantly patients, but also carers of patients with our disease into our offices, and our offices are just down the road. And to a man and a woman, throughout the course of the day, although we were trying to focus on the protocol, all they were saying to us, the panel, were, we don't know what's going on with our heart valves. We don't know where to get our information from. We don't know who to turn to. We can't get into the GP. There's no way we're going to be seen by the hospital consultant. Can you help us? And it was true for every person in that audience. And it actually took that event, despite 21 years of working in the NHS, to make me realize that it's really difficult, if you're not medically trained, to get medical information that you understand, that you can actually use to help you make decisions about your own personal health. And that got me to thinking about what we can do about that. And at that time, this was February 2023. Yeah. ChatGPT was coming online, and I just thought, can we create an app that provides patients and their carers and their relatives with health information that's delivered in plain language, that can be trustworthy, that can be accessed via the phone, that patients can use to really help them sort of navigate their healthcare journey. So that's where the journey of Onion AI started. Just, and me keeping the full-time job at MedPace, I started Onion AI. And essentially, it was based on the fact that health literacy is really poor. And I didn't really know that. I assumed that, in my clinic with 15 to 20 minutes for each patient, they absorbed all the information I gave them. They left the room, they understood exactly what I said, they retained it all, they got to their car, they got home, they recalled it, then they told their family about it. And clearly, that doesn't happen. So if you look at all the data, it's fairly consistent that about half of any population surveyed will have very inadequate to problematic health literacy levels. And if you don't understand basic medical information, what hope do you have of being able to help yourself in living with the disease you have? It's basically impossible. Now, add to that the levels of stupid out there in social media and all the misinformation that you have in social media, but you have a population that are desperate for information. They don't know where to turn. They often hear the loudest voice, the most charismatic person on social media, and they listen and they believe because they need to get information from somewhere. And if you have that combination, it is a pandemic. It is a growing public health crisis that no one is really recognizing or doing anything about.
Got another session in a few minutes and questions.
So I'll quickly go through this. So where do you find factual health information that a lay person can understand? Obviously, you can get it from your GP and your hospital consultant, but how long do you have with your GP? 8 minutes at the most. Your hospital consultant, 20 minutes if you're lucky. We've got private healthcare, access to a private GP. Again, you may have some more time, but all doctors, they're trained to assess, investigate, treat, manage. They're not really trained to communicate. So not all doctors are the same. They don't all use plain language. They don't all care as much as the next. So it's difficult. You've got NHS Online, comprehensive, but not personalized. It's not going to fulfill your circumstances if you go on the website. ChatGPT. In terms of medical advice, is it trained on a medical data set? No. And yet people use it for medical advice, and they shouldn't. And don't get me started on this lot. So, it's crazy out there. And I put this up here because, you know, as a cardiologist, I must have told thousands of people to stop smoking. Did any of them stop smoking? Probably not, because I told them to. There was a paternalism that belongs to most doctors. And I don't have the time to explain why they should stop smoking. I don't have the time to sort of go through that whole journey with them. So, you know, that sort of interaction is utterly useless. It just made me feel better because I ticked a box to say, make sure you stop smoking. But what happens to the patient? Nothing. So very quickly, Onion AI. So we've developed this app. It's Onion AI, but it's not artificial intelligence. We like to think of it as acquired intelligence. And it's basically patient-facing, plain language, science information delivered to the patient, but in a personalized format. You enter your profile, you enter your medical history, your drugs, your lifestyle, your smoking, your alcohol, where you live, your gender, etc., and it builds an ecosystem around you to basically help you understand where you're going. Now, this is my last slide. So we use an open source LLM, but we put certain ring fences around it. So as you know, most LLMs want to give you an answer, despite the fact that they don't have the training data set to do so. So we do it differently. We use a closed framework. So the patient asks the question to our conversational chatbot. The LLM goes to its training data set, gets a response, but then we RAG it, retrieval augmented generation, to a fixed trusted source of data. The LLM then basically translates what that trusted source of medical information is, and then a further chatbot or a further bot validates that answer before we give it to the user. And if we don't have an answer, either from the training data set of the open source AI or our fixed source of medical truth, the chatbot can say, I don't know. And that's the key part of what we're trying to create. Let me just, so I wish I have to stop now, don't I, basically?
For a few minutes, I'll have to get some couple of questions in as well. But
Yeah. So the lessons I've learned really from a career is don't be afraid to ask, make sure you have ideas, don't ask people to help you if you don't have any ideas to back it up. They're not going to just be there to, you know, support you and get nothing back. You know, we've created a team at Onion AI that basically covers every facet of a health tech startup. And unlike most health tech startups, we are mainly healthcare based. I have the pleasure, hunted Mark down. You know, he first said no to me. I didn't take no for an answer. And I got back to him sort of 6 months later. And thankfully, he'd left his other job and he was free. And we have a consultant gastroenterologist, an orthopedic surgeon, a GP, and we all know the pain points of healthcare. We understand what patients need, and I've got to stop.
We've got time for one quick question, or yeah. Any online, or can we go straight to the room? If not, we've got one at the back.
Yeah, we know about doctors now wanting portfolio careers. You actually used that word. Are employers and regulators anywhere near catching up with that way of work?
I didn't know I needed to ask their permission, essentially. It's I would have, you know, even during my NHS career, I had a portfolio career in so much as I was an author, writer, researcher, and a trialist. So what the other, I think, nation? Do you mean what in terms of GMC or?
Whatever it is, and that's getting increasingly tighter with specialisms from the GMC. So we know that the people want to work that way. Are we making it too difficult earlier in careers for people to develop their portfolio careers with adequate safeguards?
I think my
Is it too big a choice that we're making people take?
I think my belief, and people may disagree with me, is you're not a doctor after your first foundation year. Right? But to me, a doctor, someone who's experienced, who's making decisions on other people's care for themselves independently, that's when you become a doctor. And to me, that's when you can decide, do I have the expertise to be able to do my thing in another field, take up a portfolio career? I waited 21 years to then go into the life sciences industry because I knew at that point I was an expert of sorts in my area, and I could offer that as a carrot to a big US company, and they took that carrot because they knew I had the expertise. So I think it's folly in a way for juniors to jump into another career unless they absolutely hate medicine. But for me, medicine, I'm still a practicing doctor. I'm still on GMC register. Medicine has taught me all I know: leadership, teamwork, independence, making decisions, peer review, learning, everything. It teaches you everything. And companies, be they McKinsey, AstraZeneca, whatever, they love that. But you've got to show that you're expert in those areas before you leave medicine. That would be my opinion.
Quick question with a quick answer.
So I'm wondering, are any of those leadership team got professional software engineering qualifications?
Yes. But otherwise, no, we use a third-party vendor. So we have a software developer who happens to be a childhood friend of mine from the age of 13. So he runs a software developing company. So they built the platform.
One more over here and then we'll finish, I think.
Can I ask just for a comment? Healthcare is a teamwork, and you involve the multidisciplinary team, the patient, the carer, but also the IT department. And I get the sense that it's very difficult to get good IT people because they are snubbed by big companies. Not only that, I've got doctors who think they know how to code and therefore interfere with my work. I don't go and tell them how to doctor. Why do they interfere with my work? How do you answer that kind of question in the idea of a teamwork to support excellent patient care?
I am fully technology agnostic. I don't purport to know how to code. I don't want to code. My role is create the vision, to get the funding, and recruit the people. And someone like Mark, who does code, knows how to code, who teaches me stuff every day about coding, I leave that stuff to him.
May I come in?
Yeah.
So it's a fantastic question. Why step on toes on one side, the digital, why step on toes on the other side, clinical? I think you have to step on toes and you need people in the middle that can communicate, translate both ways. It's not them versus us and us versus them. It's, as you said, a team. Now, getting the team playing nicely together, he's a clinician who can code coming over and saying, oh, no, that's not how you write that bit of C++. No, that's wrong. And then the coder coming across, that's not how you do clinical stuff. Oh, you need an extra button or another 20 buttons to do that one thing. No, I want one button that does everything. It is a teamwork. We need to communicate better. And that is one of the problems. There's also a digital literacy issue across the board in NHS, in the public, about understanding what's an API, what's an LM, is it safe or not safe to use it? It's a big problem, change management, and it's not something we're going to solve overnight, but it's a really important problem to solve.
Thank you very much. Thank you very much, panel.